Hello, my name is Patrick and I'm a Pulmonary and Critical Care Fellow, and this is the first of a series of videos on CPET. This video will be on indications and monitoring. It's intended for fellows and providing a basic overview. During this video series, I'll be referencing these two textbooks quite frequently. This is my attempt at incorporating AI into this video series. As you can see, it hasn't gone very well. She has 3 arms, but what is correct and is very important is that she's wearing a mask. And it is this mask that during a non-invasive CPET allows us to measure a patient's exhaled and inhaled gases that we then convert into values that we later interpret as part of the test. The indications for a CPET typically fall into one of 3 different buckets. The first is dyspnea of unknown origin, and the existing workup, be it PFTs or a transthoracic echo or an image, is unrevealing. The second indication is perhaps in a patient who may have coexisting disease processes, and you're trying to understand better whether it is their heart or their lung disease which is primarily responsible for their symptoms. And the third indication is risk stratification and prognostication, and this is typically in patients with advanced heart failure being considered for transplant or in patients being prepared for cardiothoracic surgery. CPET produces lots of data. There's many graphs and lots of numbers, but most of the useful information is actually derived from these 4 measurements. They are our minute ventilation, which is the volume of air breathed in and out in a period of time, the VO2, which is the volume of oxygen consumed by the body, and the VCO2, the volume of carbon dioxide produced by the body, and the heart rate. By combining 2 of these measurements, 3 more indices can be derived: our respiratory exchange ratio, our oxygen pulse, and our ventilatory equivalence, all of which we'll cover in later videos. It's important for you and your patients to understand that this is a relatively safe test, that there need be no interruption to their medications, but that they should be very accurately recorded, especially if they're on a beta blocker or any other type of antiarrhythmic or calcium channel blocker, and that the most common adverse event includes hyperventilation with or without syncope. Contraindications to a CPET can be broken down by system. Neurologic contraindications to a CPET are attention deficits. So for example, if your patient has a history of struggling with PFTs, they will very likely struggle with the CPET. Also, if they have a history of prior exercise syncope, they should not undergo a CPET. Cardiac contraindications include testing patients when they are not fully recovered from any recent cardiac event, and 2, they're not symptomatically optimized. Similarly, patients with acute respiratory issues should also have their test deferred. That includes viral infections. And in patients who have resting hypoxemia, they should 1, have their test deferred, but 2, you should consider why you're doing the test unless it is part of a pre-operative evaluation for someone undergoing cardiothoracic surgery. And lastly, anyone with a recent PE or DVT should also have their test deferred. This is an exercise test, so anyone with an orthopedic injury or who's experiencing immobility or who is in advanced pregnancy should have their test deferred until they can adequately and fully participate. During the test, your patient will be wearing a face mask, and so regular communication may be challenging for them, so you need to be paying full attention for clinical signs of dizziness, confusion, pallor, cyanosis, and distress, and any of these clinical signs are a reason to stop the test. During the test, patients' vitals are monitored. One of the vitals that we look at is their blood pressure. We're looking for a few different things. Firstly, we're looking for an excessive rise in their blood pressure, and that's defined by a systolic blood pressure greater than 250 millimeters of mercury, or a diastolic blood pressure greater than 120 millimeters of mercury. If we remember Ohm's law, we can write out the equation for their blood pressure as follows: their cardiac output, which is their heart rate times their stroke volume, multiplied by their systemic vascular resistance. During exercise, our systemic vascular resistance reduces. This allows greater blood flow to our capillaries and our muscles, allowing for increased oxygen delivery and carbon dioxide removal. Our cardiac output increases, both at the same time, but predominantly the stroke volume first, followed by the heart rate. And altogether, this leads to an increase in our blood pressure. Normally, your systolic blood pressure should get to at least 150 millimeters of mercury. Interestingly, your diastolic blood pressure could actually remain close to the same at rest, or it may reduce just a little bit. Now, in people who have atherosclerosis and peripheral arterial disease, they're unable to fully reduce their systemic vascular resistance. And during exercise, their cardiac output increases, so their heart rate and the stroke volume still increase, but because their systemic vascular resistance is higher than it should be, this leads to a very excessive rise in their blood pressure. And this is dangerous because when blood pressures are very, very elevated, this can place inordinate afterload on the heart, which can lead to cardiac ischemia, or it can place pressure in the brain and lead to a stroke. So in addition to an excessive rise in blood pressure, we're also looking for a significant fall in blood pressure. And a fall, and that's defined by a fall of 20 or more millimeters of mercury from the peak systolic blood pressure that's achieved. And a fall in blood pressure suggests a limitation in stroke volume, be it from ischemia, a valvulopathy, or cardiomyopathy. And going back to Ohm's equation, if we look at this is what normally happens, but in people who perhaps have one of those pathologies, their systemic vascular resistance drops, their heart rate is increased, but their stroke volume starts to decrease, and as a result of that, their blood pressure drops. Patients are monitored for desaturation, and we define desaturation by an SpO2 of 80% or less with symptoms and signs of hypoxemia. Before you terminate an exam for desaturation, if the patient is using a finger probe to monitor their SpO2, make sure their grip isn't excessive, and by relaxing their grip, you should see their SpO2 increase. If this is a recurring problem during the test, they can have the probe placed on their forehead or on an earlobe. Lastly, we record patients' telemetry, monitoring for ischemic changes, which are ST depression, ST elevation, and T-wave inversion, as well as arrhythmias, looking for complex ectopy, second or third degree AV block, and change in axis or a new bundle branch block. And complex ectopy is different from isolated PVCs. So not all ST depressions are the same. On the left side, you can see we have no ST depression, then we have J-point only depression, and both of these are obviously considered negative, but you could have upsloping ST depression, and this is considered equivocal. What we do take seriously is when we see horizontal ST depression or downsloping ST depression, and these are considered indications to stop the test. So as a quick refresher, here we have 3 different tracings with 3 different types of complex ectopy. At the top we have what's called bigeminy, which is repetitive patterns where PVCs alternate with normal sinus rhythm. So here we have normal sinus rhythm, followed by a PVC, followed by normal sinus rhythm, followed by a PVC. Then in the middle we have what's called a couplet, where we have 2 consecutive PVCs. And then lastly we have what's called non-sustained ventricular tachycardia, or NSVT, where we have 3 or more PVCs consecutively at a rate of 100 beats per minute or more, lasting less than 30 seconds.